Hi everyone, this is Renee. So for this voiceover, we're going to cover three different topics. We're going to talk about CROUP, bronchiolitis, and epiglottitis. Okay, so we're going to start off with CROUP. CROUP is a term used to discuss a few different syndromes. The one we're going to focus on is acute spasmodic laryngitis. It is the least serious type of CROUP, and its age of occurrence is usually between 3 months and 3 years. It has an abrupt onset and usually occurs at night. So the child's going to wake up with these symptoms. The trademark sign is that really harsh, barky cough that the child will have. But you can also sometimes see inspiratory stridor, hoarseness, and varying degrees of respiratory distress. It is commonly caused by parainfluenza virus, and the incidence is higher in boys than it is in girls. So manifestation of CROUP. So like I mentioned in the last slide, the onset of symptoms usually occur at night. So the child's going to develop these symptoms at night and wake up with them. We will see that there's a sudden onset of harsh, metallic, barky cough. They may also have a sore throat, inspiratory stridor, and hoarseness. You may also see them using those accessory muscles to breathe. They may be frightened because of the degree of the symptoms. They may experience agitation. We could see cyanosis, so the blue developing around the mouth and the fingertips. And these children are typically not febrile. CROUP is typically diagnosed based off the clinical manifestation, so the signs and symptoms the child has. The goal for the child is to maintain a patent airway. It's very important to keep them calm and monitor their respiratory status. If they do worsen, they may need to be brought to the emergency department, so it is important that the parents understand that. The caregivers also need to keep a calm approach when caring for this child. We also recommend that they bring the child outside at night. This is really just to breathe in that humid, cold air. It can really help with their breathing status, and they can also use a humidifier indoors. Treatment and nursing considerations for CROUP. So you need to increase the child's PO intake and make sure that they're maintaining their hydration status. Typically, antibiotics are not given unless there's a secondary bacterial infection present, because this is mostly it's mostly commonly caused by a virus. In regards to nursing care, we need to treat the symptoms. We need to assess the respiratory system, assess for any recent infections, check their temperature and hydration status, encourage a quiet and calm environment. We want to teach the parents the signs and symptoms of respiratory distress. This is really important because CROUP is typically managed at home, and the parents need to know that if they have worsening symptoms, when to bring them to the emergency department. We can use Tylenol and Motrin to reduce fevers. And you guys will see in your book, it talks about using steroids. That can help with the overall inflammation status and help with the child's breathing. Moving on to bronchiolitis. So bronchiolitis is a term that refers to acute inflammation of the bronchioles. With bronchiolitis, edema and mucus will accumulate in the bronchioles, and this is going to cause obstruction and lead to atelectasis. Respiratory synovial virus, or RSV, is usually the cause of bronchiolitis. Infants are exposed to RSV from adults and older children who have minor respiratory illnesses. RSV is transmitted from direct contact with objects, surfaces, or infected people. RSV season usually goes from about winter to early spring. Bronchiolitis is generally preceded by a mild upper respiratory infection, so the symptoms will start to develop after the child has the upper respiratory infection. Infants will have clear nasal drainage, sneezing, low-grade temps, and anorexia for a few days prior to developing bronchiolitis. Infants will suddenly develop acute symptoms such as tachypnea, usually greater than 60 breaths per minute, tachycardia, or a heart rate more than 140 beats per minute, wheezing and crackles, or rhonchi, and the use of accessory muscles, and cyanosis. This can progress to severe respiratory distress, exhaustion, and respiratory failure. Bronchiolitis is suspected based off of clinical manifestations and the age of the child or infant. Respiratory secretions can be tested for RSV by completing a nasal swab or a nasopharyngeal washout. A chest x-ray can also be completed looking for hyperinflation of the lungs, which is common, and an increased chest diameter. Typically, infants who have mild bronchiolitis will be managed at home with PO fluids, rest, and humidified air. If respiratory distress does occur or the infant has severe symptoms of bronchiolitis, they will need to be hospitalized. In the hospital, we can give cool humidified oxygen if they have low oxygen saturation. They can be given IV fluids if they have poor PO intake. We need to position the child to help with their breathing. And also, if this is something that is caused by bacteria, which is rare with bronchiolitis, we can give antibiotics, and this is usually because they develop a secondary bacterial infection on top of the virus. One of the biggest nursing considerations is preventing the transmission of RSV, and that is really important to educate the family about. Hand hygiene is key with preventing the spread of RSV because it is spread by contact. You need to make sure that you are frequently assessing the client for signs and symptoms of dehydration when they have bronchiolitis. So checking their mucous membranes, assessing fontanelles, urine output, weight, and temperature, all of these things that go into fluid status. If the child is hospitalized, contact isolation precautions need to be initiated. So gown, gloves, and hand hygiene. Okay, so the last topic we're going to cover is epiglottitis. Our epiglottis is located at the back of our throat. Epiglottitis is the acute inflammation and swelling of the epiglottis and surrounding tissue. This is a life-threatening condition and most often occurs in children between 2 and 8 years old. Epiglottitis is rapidly progressive and can cause complete airway obstruction in a matter of hours. Epiglottitis can be caused from a variety of different organisms. No matter what the type, they all have the same manifestations. There will be an abrupt onset of symptoms, so parents will put their children to sleep at night and they will feel fine. And then in the morning, they'll wake up with severe difficulty breathing and a sore throat. So it happens very quickly. We can see anxiousness and frightened appearances on the child, sore throat or difficulty swallowing. They'll have a high fever. They will often be in what we call the tripod position, and this is where they're leaning forward, supported by their arms, and this is going to help them breathe. They're going to have their chin thrust out and their mouths open, really gasping for air. We may see nasal flaring, suprasternal, substernal, and intercostal retractions. So those are the intercostal spaces, and we can see them moving as the child is trying to breathe. We're going to see pale skin and cyanosis, tachycardia, and a cherry red swollen epiglottis. In the picture, you can see the difference between a normal epiglottis and one that has severe redness and swelling. So a big piece of epiglottitis is a child should not be left alone. So if we think a child has epiglottitis, we should be staying bedside with them because their condition can change so rapidly. Your book talks about the 4 Ds, which are the cardinal signs and symptoms, and they are drooling. So if a child is drooling, it could be a sign of epiglottitis. And this really just means they're not able to swallow all of the saliva back down their throats, and it's just pooling in their mouths. Dysphagia, which is the difficulty swallowing. Dysphonia, which is the difficulty talking. And also distressed. So distressed inspiratory efforts, so they're not able to get that breath in or get the air back out. So these are the 4 Ds, which may help you to remember the signs and symptoms of epiglottitis. We want to be sure that we are not using a tongue depressor or anything in the child's throat to take a culture or whatever it may be, because if epiglottitis is suspected, putting something back there, such as a tongue depressor, could actually cause the throat to close. It basically will trigger it. So we want to make sure that these children have nothing in their mouth. Okay, so this is just another visual aid to help you remember the signs and symptoms of epiglottitis. This picture uses the words air, raid, so airway closed, increased pulse. So that's tachycardia and restlessness. And anytime someone is restless, it's a good indicator that they could be hypoxic, meaning they're not getting enough oxygen, which is the case with these children. We will see those retractions, anxiety, inspiratory stridor, and drooling. Again, we want to decrease their anxiety so that we can and also encourage the parents to hold, hug, and try to soothe their child. Like I mentioned before, we don't want to examine the throat. We want to position them in a comfortable position and have emergency equipment available like a trach tray. So therapeutic management for epiglottitis, we need to achieve a patent airway stat So commonly these kids are going to need to be intubated if their airway is completely obstructed. We need to be monitoring their arterial blood gases, continuous pulse oximetry, administering humidified oxygens, antipyretics we can use for fever, and antibiotics, which they will typically be on for about 10 days with epiglottitis. Some nursing considerations for epiglottitis. We need to be assessing for signs and symptoms of respiratory distress, so monitoring for cyanosis, stridor. We want the pulse ox to be above 95%. We will maintain the airway either through intubation or providing humidified oxygen, and we need to keep them on continuous pulse oximetry to monitor their levels. Emergency equipment at the bedside, so this is super important. Having a trach tray, intubation equipment, having suction hooked up. This is important because we know how rapidly these patients' conditions can change. Also, in the initial stages, the child should be completely NPO, so nothing by mouth, and they will be supported with fluids. As they are recovering and feeling better, and we know that they're less likely to have any further issues, we can encourage oral hydration. And you will see in your book that they'll mention oral hydration, so I don't want you to get confused because this says nothing by mouth. The nothing by mouth is really the initial stages, so we don't want to put tongue depressors in there. We don't want to try to give them something to drink when they're completely swelled up in the back there.